Introduction. So my name is Brian Hatcher. I am here representing CareNet Counseling. So I've been with CareNet now for about close to a quarter of a century and have the privilege to provide leadership to that organization. So we are excited about that. CareNet describes the work we do as an extension of the ministry of local congregations. And out of that, we believe that the counseling ministry is part of pastoral ministries, but we all know that clergy can't do all that is asked of them around that. So we hope to be here to help clergy and others in congregations expand that support ministry in positive and healthy ways. So today, I'm here to help us talk about how your congregation can very much be part of improving health and behavioral health, mental health, if you will, for yourself, for those in your congregation, and for the community. I hope for this to be as much a conversation as anything. I do have a few resources we'll talk through. So if you have ideas, thoughts, just say it, and I may occasionally ask for your feedback. We'll go from there. I also am going to beg your forgiveness a little bit. I have a call that is scheduled to start at 3 o'clock. I'll be a few minutes late, but we may end a few minutes early. I'll be a few minutes late there. The world will all be fun. So we'll go from there. That's starting point. This is kind of what we're doing today. To launch, I would actually like to survey and ask if one or two of you have programs in your congregation around mental health or support that you would like to name or talk about. Yeah, go ahead.
Yeah, I will. We do have a Health and Wholeness ministry,
Okay.
And we do programming around grief, and we are starting a substance use division. I'm real curious about anybody's reaction to what we're doing. We have asked somebody from AA to help us with a 12-step to recovery study group, and the goal would be that people in that process then would identify what their barriers might be.
Okay. So let's do the AA program in a minute.
Well, wait.
Okay, one more.
Keeping it specifically AA was the point.
Right.
12 steps to wholeness.
Yes.
And so, yeah.
Okay. I'm curious about the grief program before we go there. Is it grief share? Is it a different program?
It is, oh my goodness, I'm going to blank.
I didn't even think
on what it is a 6-step program to grief recovery, and it's not just death.
Right.
Grief.
Yeah, grief is about lots of
Lots of loss. Yeah.
Love it.
Holly is our leader in
Love
that.
it.
So,
Just curious. Okay. Any others have experience around the AA and this particular program to sort of offer to this congregation?
No, I'm part of myself and 2 young ladies in the back. I'm part of Faithful Families Ministry.
Okay.
And we actually concentrate on healthy eating, healthy mental health, which we want to get more into that, but we really haven't. We mostly concentrated on healthy eating and walking and exercise.
Perfect.
But we also have NA ministry out.
Okay. You do NA, which is another 12 step, but focused on a different substance. Okay. And then, notice Nancy?
Yeah, we're in Winston-Salem.
Okay.
And we have a mental health committee. And we're trying to raise awareness of mental health and destigmatize.
Okay.
The church is a place to come. And we've developed a support group for family members that have chronic mental
Lovely, lovely.
We have a widow's group.
Okay.
We have a walking group every Friday.
Oh, fine. Yeah.
Yeah.
Okay. My office is in Winston-Salem. I'd love to learn more about what you all are doing there. Any others? Any others? Okay.
It's called the Grief Recovery Method,
Grief recovery method. Lovely.
and it's a signature program. I mean, it's a, what do you call it?
Evidence-based?
It is clinically based.
Yes.
And
Yeah. Yeah. Love it. Love it. Okay. So this is me. If you need contact information, please reach out. Happy to enter into conversations. And often with this lovely crew up front, what I do is say, oh, I know where in the state you are. Let me connect you to my folks closest to you. So because partnerships happen locally and work together. But that's all good. So these are some of the things we'll do today. Probably time we'll not spend on talking about what we're going to do. We'll just jump into it. So let's define what it is we're talking about. What is it we want to do, and what are we looking at? So mental illness. Let's actually start with mental health. You all tell me, what is mental health? Do we all have it?
Yes.
Okay. Got a strong confirmation up here. Yeah. How do you know? You wake up in the morning, you shake the cobwebs out and kind of get settled. How do you know? I'm going to be okay today. How do you know the mental health piece is there? Just what's your experience?
Good mood. A good mood.
Okay, I'm kind of chipper. All right, that's something. That's something.
Like getting out of bed.
Yes, I don't want to pull the covers over. I'm like, okay, it's a day. Let's move on. Yeah. Yes.
Sometimes it can also be physical, like you actually feel in your body.
Yeah, exactly. The physical piece as well as the emotional piece. You got it. And it all goes together, right? We can't be all together well mentally if we're not well physically, spiritually, relationally, on and on. It all goes together. It all goes together. These are some definitions given by the professional organizations out there. Basically, a mental illness is a condition that affects one's thinking, feeling, or mood. That's the mental part, right? Our thinking and feeling. And we named all of those things. So I don't think the answer every day is, am I mentally healthy or not? Yes or no. It's not just a two-answer question. I think it's on the scale, how am I doing? Some days it's a 10. Occasionally it's a 10 and a half. Some days it's, all right, it's a 5, but I'm going to make it happen. And if we're honest, most of us have a 1 day. That's real. That's real. Just some things to know. Diagnoses. So my group's affiliated with an academic medical center. We bill insurance, so we have to do things like provide a diagnosis, write a treatment plan, all of those things. And I used to resist that. More and more I recognize, no, this is how we care for people. If I go to my doctor, he doesn't just say, Brian has a sore arm. He gives a medical diagnosis to what's going on. And that's important because knowing what's going on helps us know how to respond to it. So we do the same thing around one's mental health or mental struggles. However, you and I can go today and see our counselors and have the exact same diagnosis, but have very different experiences from that diagnosis. So we may both leave with a diagnosis of anxiety of some form. But your anxiety looks one way, and my anxiety Your anxiety may push you to be hyper productive. There, just get things done, go, go, go. My anxiety may overwhelm me and shut me down, as an example. Depression, on and on. What is a substance use disorder? First of all, let's know that it is a medical disorder. A substance use issue is not a character flaw. It's not a deficit. It's not a poor decision. It is a medical condition. There are parts of our genetic makeup that drive some people more and more towards seeking the satisfaction that comes from using and overusing substances, and some folks have less of that. So it really is biologically driven. But you can see the definition there that comes from Sampson. So basically, it's when someone is using or overutilizing substances to the point that it gets in the way of function. That's when it becomes a disorder. Do we need to walk through specific components of different, like anxiety, depression, that sort of thing? I'm happy to do it, but also just want to be thoughtful of our time. I live at home and I see folks. The new way to take notes is get your phone out, take a picture. We didn't have that when I was in school. That's a good thing. So there's anxiety, there's depression. Very common. I'm going to suggest that most everybody in the room has their experiences of both of these. The data consistently shows, particularly prior to 2020, that somewhere between 20 and 25% of the U.S. adult population either has or would qualify for a mental health diagnosis at any point in time. This point in time has this group of people in it. That point in time is over. This point in time has this group of people in it. So, what I mean by that is, just because you're eligible now doesn't mean you're eligible tomorrow. So having a mental health diagnosis doesn't mean always, doesn't mean that it lasts forever. There are some diagnoses, like the flu. You get it, it runs its course, you move on. There are other mental health diagnoses that are more chronic in nature. A person learns to manage and live with those versus letting it run its course. Like cancer, those more chronic things can be in remission, but that's different than being gone.
Excuse me, I have a question.
Yes.
What's that last anadromous? What is that?
I'm supposed to know, come on.
Is it loss of pleasure?
That's it exactly, yes. Things that I used to enjoy don't bring me pleasure anymore. And I have to be careful because when I was 25, I used to enjoy running 5Ks. I don't enjoy that, but it's not because I'm depressed, it's because I'm old. So we have to be careful with that, but yes, that's what it means. Things that normally we would enjoy, we would derive pleasure from. I went and did it yesterday, I had a great time. I went and did it today, and I was just going through the motions, kind of thing. That can be relationships, it can be activities, it can be your work. It doesn't matter what the it is, but it's loss of pleasure in things, usually. Unexplained physical pain, again, I've got a lot of these gray hairs. That brings its own physical pains and aches. So we just have to be cautious about what we're looking at. And of course, there is postpartum depression, which affects, of course, some in ways that will affect others.
I think I've read that over the course of a lifetime, as high as 50% of the population could have at one time
Yes.
been diagnosed.
Absolutely, absolutely. I also said, and I want to come back to the, that 20 to 25% of the population was pre-COVID. What we know is since COVID, every mental health condition, every stressor is exacerbated. The early days of COVID, when we were all very isolated and quite frankly, very unsure of what the world was, just led to a sense that what may have existed and you kind of managed, it got bigger for all of us. For all of us. So I'm still waiting for the federal numbers that say post-COVID, that number is not 20 to 25%, but 30 to 35%. I don't know that those will be the numbers, but I do expect that they will be different now. I'll also add there that there have been some benefits to COVID. One, stigma to behavioral health, mental health is down. I think most of us just realize it's real, I hurt, I need to call somebody to talk. So the beauty of it is we worry less and less and less about that. And we're not only we're talking professionals, we're talking with each other. And we're talking in our congregations. I've heard ministers preach on mental health in general, but also just their own struggle around things. And I think that level of vulnerability has a positive side to it. It's a good thing. And I'm not speaking directly to the slides you can tell, but another benefit that's come out of COVID has been telehealth in general, telebehavioral health specifically, and we need it. It's a really good thing. It provides access. Prior to COVID, I can tell you my group, we did a little telecounseling now and then. It was usually on a case-by-case basis that we had to get approved by insurance and that sort of thing. And it usually was something like, I'm treating this college student and they are going to do a semester abroad, but they don't want to interrupt their therapy, so Blue Cross Blue Shield approves it and our counselor can talk to them while they're in London for the summer. Well, not anymore. It's not that exclusive. All of us can do it. It's much easier access. Here's the interesting thing about that though. Now, 2.5 years later, post-COVID, well not post-COVID, post the onset of COVID, and we're kind of settling into something new. Most all of our CareNet centers have waiting lists. And initially that disturbed me to no end. What I've learned in recent days is someone calls one of our offices, asks for an appointment. They are told, if you would like to see a CareNet counselor face-to-face, you're number 84 on the wait list. As soon as you get there, as soon as we have an opening, we'll call. Or we could do telehealth and probably schedule you within 2 weeks. People are choosing to wait for the face-to-face rather than go ahead and move to the telehealth. I haven't made good sense out of that yet, except we're all just yearning for human interaction, that kind of stuff. But I think it will settle out, but it's all there. Back to kind of signs and symptoms. These are some of the more chronic scenarios, if you will. Bipolar disorder is very real. It is the cycle between what we call mania, or very exaggerated energy cycles, and depression, and it goes round and round. Not always, but usually when a person is diagnosed with bipolar, it is something that they will need to learn to manage over the course of life. And congregations can be very helpful to that in providing support and stability and resources to both that person and the family. PTSD, a growing phenomenon in the world. It is the result of experiencing trauma and it's the lingering effects of that. And those effects are usually flashbacks that can be, during the day, during normal kind of experiences, or they can be dreams at night. But they're not just memories or just dreams. These are actually reliving of an experience that occurred. And they trigger very difficult moments for folks.
I'm curious
Yes.
about the character flaw under bipolar.
Many people think that, please note, not. This is not just this, it's not just that. The reason I put this first word under there, my daughter, who is now a third-year med school student and pretty stable in her life, used to come off of high school and declare that she and all of her friends were bipolar. And I would say, no, you're not. Yes, we are, Dad, because I was mad this morning and I couldn't stay awake this afternoon. I said, no, you're a teenager with hormones rolling through you, and you're just moody, And of course, psychosis. I actually, with the psychosis piece, I have a little exercise, and I think I'd like to try and do this with folks. We're going to take 3 minutes, and I would ask if you're sitting on the row with someone, if you would partner up, and if you're not and you're comfortable with it, could you find a partner just to spend these 3 minutes with? And I'll tell you what we're going to do so that you can make a choice about that. I'm going to ask one of you to sit and just face the front. I'm going to ask the other person to actually be a voice. So let's talk about psychosis for a minute. Psychosis is the experience of witnessing things that are not occurring in a way that others experience them. Notice how I said it. I did not say psychosis is the event of experiencing things that aren't happening. Because the person who's having the experience, they are very much happening. Very much happening. So this experience that I want us to walk through, for me, is the best example of having that experience without actually being in a psychotic moment. And I think it creates huge empathy for those of us who don't live with that. So if you're comfortable, if you're not, please know there is no, you don't have to do this. But if you're comfortable, I would like for us to pair up. I would like for one of you to simply sit and look forward. And I would like for the other person to just say things in their ear. Say things in their ear. And frankly, I don't care what you say. It can be logical, it can be illogical. I wouldn't say to say anything that really is a directive to anyone, but do that. And then, while you're doing that, for the person who's facing forward, I'm going to just keep talking and I want you to pay attention. Okay? So, find a partner, if you would like. Okay? Everybody good? Okay. Okay, so if you are the voice, if you would, just start speaking into your partner's ear. Again, say whatever you like. It can be logical or illogical. I would ask that you not give any directives. Don't tell them to do something. But just be a voice in their ear. And while they're doing that, I'm going to keep talking, and I want, if you're the person looking forward, I want you to pay attention to me. Okay? So, ready, go. So, I'm going to flip on now to the next slide while we do that. So, what occurs in the brain when we're using substances that we that may be harmful to us. It is there is a disease in the brain that triggers the compulsivity to seek substances. It drives us toward that. The introduction of substances earlier in life can greatly increase the likelihood that someone will have an addiction. Exactly, that's the point. Yeah. Substance use can occur with other things going on, so you can be depressed and have substance use. You can be anxious. You can have a medical condition. For someone who has a substance use, if they get to a point where they are sober, to use the language of AA, relapse is a real expectation, and we should know that. Okay, pause. Okay, if you would, come back, just, if you moved and you want to go back to your seat, you're free to do that. I wonder if anyone would describe what was happening. If you were the person looking forward with someone speaking in your ear, what was happening?
Oh my gosh, sensory overload.
Sensory overload.
It was crazy.
Yes.
Couldn't hear what you were saying.
You couldn't hear what I was saying because...
It's hard to keep your attention.
Exactly. Imagine that's your life on a regular basis. Imagine this was a controlled environment. We could stop it, we could start it. I put some parameters around what was said or not said. Imagine none of those parameters are in place. That's what's happening all the time. And often it's not just one voice, it's many voices. And often it's not just the person sitting next to you, it's a voice of power in one's life. Someone who had a significant relationship with them, a person of authority. Often people hear the voice of God. What's named is the voice of God. And oftentimes the things that are being said are not just gibberish. We stayed away from the directive because that's a whole different level of sort of feeling that folks have. But the directives can be very, very, very powerful. And I do that. And under different circumstances done if we were meeting for a whole day, we would actually do triads, and I would have two people speaking, and then we would rotate around so everybody had the experience. But the point of that is, if you experience or hear someone who's living with that, I want you to have a level of it. What do you do? Let's talk for a moment. What do you do if, I'm so far off my slides, they don't even matter at this point. So I'm just talking. But what do you do if you're in a situation where a person is experiencing delusions, hallucinations, that can be auditory, visual, sensory, whatever? How do you handle that? Any thoughts?
Are you talking about an active psychosis, or are you talking about someone who's got a managed disease but is still symptomatic?
For now, let's talk about an active psychosis. We leave this room, you're the first one out, and when you go whichever way you do, you run into a person who is pacing the floor, talking out loud, saying things that are hard to understand. What are you going to do? Because that's real, it happens.
Well, would it be like either a schizophrenic or bipolar, or it's
Could
one
be.
and the same?
Good. Those are different diagnoses, but the psychosis is the same. It can show up in depression, anxiety, bipolar disorder, schizophrenia, substance use. Quite frankly, just after a really stressful day.
When she was whispering in my ear, and I felt, because I know I have what is it, adult, something, ADHD? whatever?
ADHD?
Yeah, I have a little bit of that. So when she's whispering in my ear, and I'm trying to hear what you're saying, I'm like, Lord, do I need to stop and help her? What's going on?
Yeah, it's all over the place.
Would you direct them in simple ways back to the here and now? Like, I like your shoes, man. What color are they?
Okay, great example. Great example.
I
So,
like, I like your suit.
Yeah.
Why don't you get your suit from?
yes, so distraction is actually a really good intervention. Yeah, just like when my daughter, as a kid, would fall and skin her knee, she wanted to hyper focus on her knee, and as soon as it turned red, there's mine! You know, one way to manage that was to distract her. Hey, look at that lamp, isn't that cool? Or, hey, I got ice cream in the freezer, you want some? Kind of thing. And while we're doing that, tend to the wound. So distraction actually is a good thing. Now, it's also really difficult if they are very focused. The one thing I would say never do is disagree. Disagree. So, as an example, I went to visit a man one day that I knew lived with this kind of condition. He was pacing his front porch when I arrived, and I didn't go up, but I went to the edge of the porch, and he wanted me to help him remove all the snakes that were climbing up the wall. I didn't see a snake. Some mistakes could have been, Joe, there are any snakes here? Oh yeah, there were. For him, there were snakes. What do? First thing you do is never disagree. Now, you also don't have to agree or buy into what they're saying. It would have been fine for me to say, I can't see them, because that's true, right? But not, there aren't any snakes. So, to start the conversation with where they are, if you can redirect them, that can be a helpful thing. Some forms of redirect, we call it grounding. So you want the person to kind of be reconnected to where they are right now. Getting as tangible as possible is helpful. I like tactile. So I might start by putting my hand on something and ask if he would be willing, 3-4 pews back, put your hand on something. And we continue to have whatever conversation he needs to have. When I can, Joe, can you tell me what you feel in your hand? The more he or she can actually describe and feel, that's a good thing. And it can be, can you tell me about your breath? If you can help slow breathing, it can be a good thing. Get help. That's smart, and if they really are in a paranoid state, and you pull out the phone, that could be a real huge trigger. So you want to negotiate that. You want to talk that through. Let them know that you want to make a call, who you plan to call, why you plan to call, that sort of thing. And you don't necessarily have to get them to agree, but it is helpful if they can understand what you're doing before you actually do it. If that's not possible and you just need to call, just call. You might step away and do that. Ensure that there's nothing around that can be used to harm self or others, and that can be anything. It may be a chair sitting on the porch, staying in that example. Quite frankly, it could be the porch itself. So we can jump off of that sort of, so you can't remove everything, but just be thoughtful. I would not move too close. You also don't want to stay 100 yards away. Keep some level of distance. I would not try to make contact. Those kind of things. Get help. Promises. Do not make promises you can't see through. I'm gonna drive you to the hospital and we're gonna make this go away. You may not be able to do that. One, you may not be able to drive to the hospital. So just be very thoughtful about those things. And it will end, even if you have to stay with it for long. That moment will come to you. Clergy, how many folks in the room are clergy? Yeah, a good number. So clergy or not, you're all people of faith and you're here because you care and you want to to go. Mental health and religiosity, so to speak, can get real blended real quick. We said earlier, the voice sometimes that folks might hear can be attributed as the voice of God. And if that's the case, then they are getting the highest voice that they can imagine getting. And that means if I'm told to do something, I need to do. So as people who may enter into these moments, just being aware kind of those things, staying grounded yourself so that you can distinguish between what is your reality and what is their experience is very helpful. Very helpful. They may believe they're being punished or, quite frankly, rewarded for something that either they've done or something they've inherited, that sort of thing. They may believe that they're being possessed. You can see all those. The themes, which I think are always very interesting. Generally speaking, folks who live with theological themes such as guilt, shame, judgment, etc., are more likely, not grossly, but more likely to have experienced or be moving toward experiencing a psychotic moment than those who live with themes of grace and love, justice, peace, those kind of things. So just the way we offer our theological understandings can be very helpful to folks. Tons and tons and tons of data suggest these days that folks who are active congregationally are just healthier in general. That includes our mental health as well. There are lots of theories about that. Quite frankly, I doubt scientifically we can pinpoint what that really is. At the very least, there's the social connection to it. But we also cannot minimize the spiritual element that's part of that as well. So inviting people in, which is different than coercing people in, to our community, our faith community, is a really, really good thing just for health purposes. Yes. So, I love that there are programs that congregations either develop or move into that are helpful to our mental well-being. As clergy or a caregiver in a congregation, if you are working with someone you believe needs more professional help, these are some of the different types of help. It's not exhaustive list, but it's a list that's good enough. Probably the thing we're all most aware of is talk therapy, counseling, psychotherapy. You call a counselor and you go to their office or do telehealth and you spend 30, 45. It used to be a 50-minute hour, but done away with that. But I still like it. It was a good structure kind of thing. But talking through the difficulties of life and kind of reframing our understanding of those can help us do well now and better along. Medication therapy, there are medicines that are very helpful to folks, whether it's a moment or a long-term scenario, to our mental health kind of status. The research continually shows that the blend of talk therapy and medication therapy is best case scenario for most. And there are other alternative therapies. I've got a list, but I'm curious. When you hear alternative therapies, what comes to mind for you? I heard shock therapy. That's one. That's more on an extreme level, and we could actually add to that inpatient, residential. Those would be some. Other kinds of alternative therapies?
Cryotherapy.
Cryotherapy, yes.
I think of Reiki.
Reiki.
Acupuncture.
Mindfulness, Reiki, acupuncture. art therapy, music therapy, equine therapy. And after equine therapy, now every mammal in the world has a therapy after it. There's a cat therapy, you know, all of that.
And I don't know for sure what the word comprehensive means, but I recently read a lot about how nutrition, exercise,
Yeah.
rest,
Yeah,
the core
sure,
components. of
sure,
health.
yeah. Comprehensive could be holistic, and that would be what we're talking about. So the healthcare system, based on the way we pay, the way we diagnose, the way we treat, is very segmented. You know, I go to this specialist to treat this part of my body, this specialist to treat this, you know, and that's true with our cycle as well. Comprehensive, holistic, integrated, all of those can go together, where we're really looking at a whole picture. So your nutrition affects your not only your physical well-being, but your mental well-being and your spiritual.
I have read that exercise and nutrition can be as effective for some people for depression.
Oh, absolutely. And not only is it effective for treating, it's effective for preventing. Yeah, yeah. If I could ask every congregation in North Carolina to do two things that would improve the mental health status of our whole state. One, have a walking program. That's easy to do. Just have times and places where groups of people get together and walk. The community of that is incredible. The physical movement does more for us than we ever imagined 50 years ago. Just the movement. And it's not just physical, it impacts our whole being. And the other would be nutrition. Nutrition, nutrition, nutrition. A favorite story I have around that. Years ago, I was part of a Duke endowment study around clergy wellness. And for the pilot program of that, because of the Duke endowment, these were United Methodist clergy beta. Several clergy were recruited. They got a health coach to work with over the course of the year. They got I forget the dollar amount, but a scholarship that they could do anything related to wellness. Some joined a gym, some bought a piece of equipment for their home, some went on a retreat, et cetera, et cetera. So, and they got, if they didn't have, they got connected to a primary care physician. Program started with a physical, and they had check-ins through the program. And I was one of the health coaches and on the design team for the program. One of my clergy that I was coaching in our second session came in tears, and I was really curious. And he said to me, Brian, I've been in this church for 2 years. Everybody knows that I love dessert and sweet tea. And my ministry is pastoral. So I spend my time visiting lots of people. What do they do when I show up? They have a glass of sweet tea and a slice of pecan pie, whatever. Clergy are nice people. I don't want anybody's feelings. What do? I eat it. I was like, well, okay. We can slow down. That's a good thing. He said, no, here's the thing. I went to that physical they made us do. The doctor told me that I was diabetic, and I could either change my lifestyle or I needed to call the funeral home and start making arrangements. I mean, the doctor was that. He said, I don't know what to do. He said, so the next Sunday, I had a sermon, but it wouldn't come out. And I broke into tears and told them that story. He said, the most amazing thing started happening. I learned over the course of the year. He said, we do a lot of Wednesday night and Sunday night dinners. You know, everybody brings a dish. He said, they changed from fried chicken and casserole to salads. He said, now when I go visit, They give me water and apple. His life changed over the course of the year because of the nutrition and his vulnerability. So if I could have every congregation have a walking or some kind of fitness program. Walking is so easy and so good for us. And pay attention to nutrition. And you can do all of that in good theological contexts. That would change our state. So it's just easy. And then when people are having a hard time, for us to have the grief programs, to have the addiction programs right here, it goes so far. I rambled. I apologize for that.
It's 3:01.
It is 3:01. The dean of the Vineyard School is going to expect me to be on the call in a few minutes. But I'll take 5 more, and we can, any questions you have, anything we need to talk about as a group. See what I missed. These are some ideas, some things you can do. Questions, thoughts? There you go. The SALT is a good acronym. We talked about if you walk into a difficult situation, smile. If you have a pleasant demeanor, that's going to help them feel less threatened. Apologize, not for their behavior, but I'm sorry I'm interrupting. It doesn't matter why. If they know that you're there in a humble spirit, it's going to help. Acknowledge what they're experiencing. Practice active listening. Listen actively, be patient. Reflect what you're hearing. So what I hear you saying is, but don't mirror it. And we can talk about that if we need to. And then always think. Always. So that posture is very helpful to people who are in stress situations. And we talked about these earlier. Okay. So, questions, thoughts? Yes?
Can that apply to anxiety?
Oh, absolutely. Absolutely. Yeah. It's just a good way to be with folks.
I think for this group, it's maybe helpful to make the comparison that interacting with someone who is experiencing psychosis or a psychotic episode is not terribly different from someone experiencing dementia. Their reality is different. A lot of folks probably in this room have interacted with someone with dementia, and the same is true with dementia, be it Alzheimer's or dementia that's related to something else. When someone says, oh, you're my good friend, and you don't know who I am, you certainly wouldn't say, no, I'm not, because you know that I'm experiencing dementia. So it's the same, the reality is distorted. A lot of times there's heightened agitation, someone might be confused, might not know where they are, might not know who you are, and I think it maybe sounds a little less scary when you think about the similarities between dementia and active psychosis, but they are very similar in their responses.
Great comparison. Thank you for naming that. I would also say psychosis does not mean danger 100% of the time. We always want to be aware and mindful, but there are plenty of people who live with very difficult chronic scenarios who are the least dangerous people in the world. That's just the truth of it. So, TV, other scenarios that kind of painted a picture. Just, do be careful, do be thoughtful, do be mindful, but don't always be afraid.
And don't be threatening that.
Yes, that's the main thing. Don't create a dangerous situation for your own pleasure. Thank you all so much. It's been a delightful day.